Good afternoon, everyone, and thank you for joining again the COVID-19 in Children seminar series. My name is Roshni Matthew. I am one of the co-directors of this session with Dr. Alan Schroeder. Today we have a very interesting session on disparities and racism in the time of COVID. And Dr. Schroeder will introduce our speakers in a minute. Our upcoming sessions, there's a therapeutic sessions next week, and then following that, we'll have a session on COVID-19 and the heart, and then we'll take a short break for Thanksgiving. Today, we will start off like many of our sessions with an evidence quick hit with one of our trainees. It is my pleasure to welcome Chris Puntaseca. Chris is a second-year medical student at Stanford, and he's originally from Wayne, New Jersey. He's a Knight Hennessy Scholar here with interest in global health. Welcome, Chris, and thank you for presenting. I'll hand it over to you now.
Thanks, Roshni. Today, I'm going to be discussing some of the big news that came out this past Monday regarding Pfizer and BioNTech's COVID vaccine. Before I get started, some disclosures. Some of the data I'll be discussing is drawn from the press release that came out from the two companies this past Monday, as well as what's publicly available on clinicaltrials.gov. So this data has not been published in a peer-reviewed journal. Some background on the Pfizer study. It's a seamless phase 1 through 3 randomized, placebo-controlled, and double-blinded study. They're looking at a synthetic mRNA molecule that codes for one of the spike proteins on the SARS-CoV-2 viral surface. The vaccine is given in 2 doses, 21 days apart, and they recently expanded the trial to include children as young as age 12, though for analysis purposes, they'll be stratifying into 3 age groups. Looking at the phase 1 and 2 safety data that has been published, we see a pretty mild safety profile, especially local reactions, mainly mild pain at the injection site. And then for systemic reactions, fatigue tends to be the most common complaint, especially among younger generations after the second dose. But again, most of this is mild to moderate at worst. And then on Monday, we got our first glimpse at some of the phase 3 data in an interim analysis. That analysis took place as soon as 94 total COVID cases had occurred between the entire sample. They announced in their press release that to date there have been no serious health concerns. And at the time of the announcement, there were 43,538 patients enrolled across the whole study. So assuming a 1-to-1 randomization ratio, which is what's called for in the study protocol, that corresponds with slightly under 22,000 patients who are vaccinated. And the big number that everyone's been talking about is that greater than 90% efficacy that Pfizer has announced. What exactly does that efficacy refer to? Essentially, vaccine efficacy is the risk reduction associated with getting a vaccine. So, for example, if we vaccinate 1,000 individuals and give another 1,000 a placebo, we can compare the rates of COVID between the 2 groups. For example, if 20 who got the placebo come down with COVID versus 10 who got the vaccine do, we can say, okay, effectively, half of those 20 were protected by the vaccine, corresponding with a 50% efficacy rate. Likewise, if 100 placebo patients get COVID, but only 1 in the vaccine group do, that would correspond with 99 patients being protected out of those 100 and a 99% efficacy rate. We can calculate VE using the formulas on this slide, which simplify to the complement of the risk ratio. And we can apply that to what we get as far as data go in the Pfizer announcement. So again, we know 94 total COVID cases. We're looking for an efficacy over 90%, which is what they cite. And we can calculate out essentially worst case scenario. So maintaining that 90% efficacy and assuming equal group sizes, that means there can be no more than 8 COVID positive cases in the entire 22,000 vaccinated cohort. And that would correspond with 86 cases among the control group. Those numbers would correspond with a 90.3% efficacy rate, which is as low as we can go while maintaining that 90% threshold. And it would also correspond with estimated case rates of a little under 4 in 10,000 in the vaccinated group versus 4 in 1,000 in the control group. So again, a highly statistically significant and exciting difference. Putting that 90% in context, the yearly flu shot per CDC is about 40 to 60% efficacious, and the FDA set a threshold of 50% for emergency use authorization for any COVID vaccine candidates. But of course, there are some remaining questions. So right now, we don't have any long-term safety data. These vaccines have only been used for a few months, though Pfizer projects that by the third week of this month, they will have met the bare minimum requirements per FDA guidelines for emergency use authorization. There's a scalability question. So again, the companies project 50 million doses ready for distribution by the end of the year and 1.3 billion in 2021. But there's questions about the feasibility of distributing those doses, as well as refrigeration concerns. So these mRNA vaccines are stored at negative 70 degrees Celsius. So the question, if we have the infrastructure in place, especially in rural areas, to actually distribute and transport those. There's a question of external validity. So the press release cites 30% of US participants come from racially and ethnically diverse backgrounds in the study. It's yet to be seen until we get an actual breakdown of that demographic data, if it's an accurate reflection of the US population, especially amongst lines like socioeconomic status. Question of follow-up. Patients are expected to come back 21 days after the first dose to receive the second. What percentage of patients can feasibly do that, and what percentage of patients do? The question yet to be answered. And then finally, I'd like to know what the COVID cases in the vaccinated group look like. So are these more severe cases? Do they tend to be more mild cases? And is there a relationship with age and the efficacy of the vaccine, as that'll ultimately guide prioritizing distribution and use if and when the vaccine is approved? And with that, I will turn it over to the main speakers for the day.
That was a terrific presentation, very clear and highlighting all of the relevant data. Thank you so much for that. And I'm already seeing a good question popping up in the Q&A. We'll see if we can't try to answer that on the Q&A itself or at the end if we have time. But I want to introduce today's speakers and have a little context for this presentation. Our division in the spring had a sort of a mini version of this series and tried to focus a couple of our research days on COVID-related topics. And Drs. Powell and Hoang gave really an outstanding presentation on the topic we're going to hear about today. So I begged them to do it again. This is a bigger, better, and certainly more updated version of that talk. And I'm really excited to hear more about it today. And just some quick introductions. Dr. Powell, who I believe will go first, she's almost a Stanford lifer. She had a brief jaunt to the Ohio State University for medical school and joined our faculty here as a clinical assistant professor a few years ago after finishing her residency and chief residency at Stanford. She now leads some of our efforts at one of our affiliate Watsonville hospitalist programs, and I think most relevant to today has done some remarkable work on the DE&I front, particularly has co-led the Stanford LEAD program, which is a leadership education in advancing diversity, which was the recent recipient of the Stanford University's President's Award for Excellence Through Diversity. And this was a huge honor, really, and a testament to the success of the program. Dr. Kim Hoang came to us from Texas a few years ago. She completed her residency and chief residency at Baylor, and then joined us as a pediatric hospital medicine fellow, where she's done some really important work on shared decision-making and goal setting for our hospitalized patients. She then was kind enough to stay on as faculty in the division of pediatric hospital medicine and is an assistant clinical professor. Among her many hats, she has been a pivotal figure in our division's DE&I effort. So with that, Dr. Powell.
Thank you so much, Alan. I am sharing my screen now and my presenting slides. Can everyone see those okay? Great. So thank you so much for a wonderful introduction and also welcoming us here today to give this really important talk. We wanted to really kind of address health disparities and racism in this time of COVID-19. And as Alan has mentioned, we gave this talk to our division with a lot of great discussion that carried on afterwards, and has also kind of gotten our group together to look at some of our practices as well across our division, but also just in light of the demographic data that's been coming out, I think it's worthwhile that we dive into this. So thank you so much. So when we first kind of were seeing the actual cases that were coming out, we know that many of those that were primarily affected were in our older adult population. And, we had a false sense of security that, our children that were going to be relatively unscathed by the pandemic and COVID-19. However, news reports started coming out very quickly that we started to see children here in the US, as well as in other countries, that were disproportionately affected by COVID-19 and also dying. And when I thought of this slide in this presentation, I go back to Charles Prober, who's a wonderful educator in the School of Medicine, of the why here, why now. And as the stories were coming out, I continued to see Black and brown children that were disproportionately not only affected by COVID-19, but also dying from this disease, and really trying to understand why are we seeing this health disparity so disproportionate in this community, and what are the things that we should be doing as clinicians, as researchers, as people who are trying to address and mitigate health disparities during this pandemic. Overall, when you look at the data right now, fortunately, CDC has had more robust counting of the number of cases. And as of November, over 900,000 cases of COVID-19 were reported, which represents about 11%, which is, in my mind, quite high of the number of positive cases that we're seeing in our children. Fortunately, we've seen a very small number of those cases result in fatalities under the age of 21. However, the CDC has been tracking the data amongst our Hispanic, Black, and Native American communities, and seeing an overrepresentation of children who are actually dying from COVID-19. It's very staggering to see this disparity when you account that 78% of these children are children of color, 45%, that's about half, are Hispanic, Latino, 1/3 are African American, and 4% are Hispanic, are Indigenous and Native American. And what's also very interesting as we look at this data is that over 3/4 of the children who have died from had underlying conditions, including asthma, which makes them far more vulnerable to the complications related to COVID-19. Most commonly, we saw things like obesity and cardiac issues, but nonetheless, I think that will highlight some of the structural and also some of the socioeconomic pieces of why we may see these diseases more prevalent in communities of color. And also understanding this data is going to be really helpful for how do we target our strategies and how do we address to mitigate these disparities in our communities. Also, you can see this in a graphical form. And once again, it just kind of confirms what we've already suspected, seeing in our adult population, but now also seeing in our children as well, the overrepresentation by Black and Latino children who are both hospitalized, but also have a higher rate of death related to COVID-19. Also, I like to always look at our own state's data. And what's been really interesting in seeing the California Department of Public Health as they've been tracking COVID-19, we can see once again in California, we have an overwhelming representation in our Latino population, where we're seeing over 50,000 cases in our children who have COVID-19 and represent over half of the deaths in the state. Fortunately, you can see in the numbers here, it's very few, but nonetheless, that is a disparity that we need to tackle and address very urgently. So one way to kind of structure this as we kind of go through our talk is first thinking about something that I think, as clinicians and as trainees, we learn very early on, particularly when it comes to pediatric health, is social determinants of health, and how we really kind of look at the conditions that our patients are living in, particularly for our children who may be more at risk based on just a function of their environment, and actually can have poor outcomes and higher risk for diseases. Also looking at the conditions, and particularly looking at school and workplaces and neighborhoods, as well as also looking at how these places can contribute to our own social engagement when we think about how COVID-19 has been spreading, and also how this may impact the overall well-being of the family and the child. Also thinking about resource and resource allocation can enhance the quality of life significantly if we really look at this from a population health outcomes, and just thinking about further examples of how we can use this as a way to also mitigate these disparities is looking at like housing costs, access, also public safety, access to healthy foods. And all of these are major factors in terms of that can make us understand why these disparities exist and persist across our country. Specifically, we also wanted to look at, some examples of these social determinants of health and how they've actually been exacerbated during this time of COVID-19 and this pandemic. And really, this is just a very short list. You can find this on the CDC, but I take this to heart, particularly with where I work in Watsonville, where I actually see kind of these active determinants actually impact our patients and particularly our children in terms of their own exposure to COVID-19, particularly looking at some of the biological risk factors from environmental influences, poverty or low income, limited job or social mobility, thinking really of our families in terms of the parents and the overrepresentation of parents that are essential and frontline care workers. Also, the access earlier on was very concerning to PPE, so really protecting our essential workers. And then also, if you think to the East Coast, particularly New York, the reliance of public transportation, particularly for crowded subways and buses, and how that may have increased some of the spread, and then how that can also translate to spread in our children. Looking at our living conditions, as well as looking at insurance and those who are underinsured and how this may impact their access to care, and also looking at how we address education and poor health literacy with designing communication and also ways to mitigate the spread of COVID-19. This is coming from the UC Berkeley Labor Center that specifically looked at that data to tease out exactly who is being most impacted in terms of our workforce. And we must consider that for many of our workers of color, they're more likely to be employed as frontline essential jobs, and this will put them at risk of workplace exposure, which, and as a result, really kind of exposes the children, particularly since most children now are at home, so therefore they are being exposed in the household. And we really have to break this down across our demographics when we look at our population here and how we can kind of address the spread. Another way of looking at this is also looking at the systemic inequalities that already exist in healthcare. This is something that I am very passionate about, and also look at very closely in terms of how do you build strategies to combat health disparities. So as we mentioned before, looking at just kind of the higher rates of underlying disease, mostly predicated by some of the social determinants of health, access to care, but also looking at our own workforce and our sometimes as providers having the lack of cultural competency and humility when interacting with our patients. Also knowing that there is an under bed and structure of structural racism, which I think has become more of a heightened awareness during this time of social and civil unrest. But really, how do we look at these things and how do we dismantle that? And recognizing that COVID-19 really is just a public health crisis that has exposed the huge racial and ethnic inequalities and disparities and some of these structural disadvantages in our communities, particularly in our minority and marginalized communities. Also, we want to address the bias and systemic inequalities in our own workforce, and that knowing that sometimes when we don't have a really robust, diverse workforce in our healthcare sector, this can actually make for some challenges with our minority patients in terms of trust of their healthcare providers, as also some concerns with a lack of cultural incongruity between physicians and patients, especially for Latinx patients, where they comprise over a third of our population here in California. But in terms of the physician workforce, only make up less than 10%. Also, how do we mitigate unconscious and conscious racial bias in the healthcare setting, especially when we were initially thinking of some of our approaches to COVID-19, how these biases actually can impact some of our strategies. We really want to make sure that we're tackling that, as well as, once again, addressing adverse social determinants of health, and that these factors, if they're not really talked about in our clinical setting, they can actually lead to wide variation in our care and our treatment options for our patients, particularly in our communities of color during this time of COVID-19. Kamara Phyllis-Jones, she's a senior fellow at Morehouse School of Medicine, is a longstanding physician and advocate for understanding structural racism. And really kind of, if you look at how do we get here, and I think that's a question a lot of people have had of like, how do we get to this point? It's really looking at our history of how this country really has had a long history of racism towards communities of color and marginalized groups. And specifically segregation in the terms of access to healthy foods and green spaces and excess exposure to environmental hazards, which is why we have things like more obesity, more heart disease, and more asthma in our children and also in our adult populations. We also have to think about just the human factors. And I think even now what's been really interesting to see is the variance in approaches across different states. And just knowing that there is a way that we must address this too, if we really want to have a robust approach to reducing these disparities, looking at just how patients have their own maybe distrust of our healthcare system. Also just the actual fear or maybe late access of seeking care or medical care when necessary. Also taking into account cultural, societal, and religious beliefs that are held by communities, and even sometimes a belief of disease fatalism that can be seen more present in our minority communities. And then really thinking about just behavioral choices. I think right now, especially as we enter the holiday season, we will see what will take place, but it's really hard to change behaviors that have been so kind of integral to our culture and to our own way of social norms. And how do we mitigate that, but also how do we keep our children safe during this time? And particularly with thinking of strategies to reduce large crowds and reduce gatherings, and also just wearing masks at this time. So this is just a short list of recommendations. We will open up the end of our talk to have more conversation. But really what we encourage everyone to really think about is assessing and addressing the needs of marginalized and vulnerable populations during this time to really combat the systemic inequalities and health disparities. Also, I think it's very critical and important that any information, any strategies that you have that are going to combat health disparities, and particularly during this time of COVID-19, that you're reducing any language or literacy barriers. All too often, I've seen that we've provided resources that are at a 12th grade reading level when some of our patients have maybe just a first and maybe very little education. So making sure that whatever strategies we have can actually provide robust resources that are culturally relevant and multilingual. Also increasing our access to care and testing availability for COVID-19. I think that's improved as we've gone along during this pandemic. But I know that for community as centers, FQHCs, those that are maybe lower resource, this is continually an issue of just access to care and making it equitable. And also, we should all be engaging in these advocacy efforts and really reaching to our community to really create community-based partnerships to support our patients and families during this time. And if at all possible, dispelling any stigma or fear of disclosing the COVID-19 infection, because this can actually deter our patients from accessing care and actually impact our children more greatly.
Thank you, Carmen. And Carmen touched on the role of structural racism and this health equity that we're seeing in our pandemic. And so with this next part of the talk, what I will be focusing on is how racism has played this pivotal role in this pandemic and how it's impacting the children of our country. Next slide. So as in March and April, we started seeing, as the pandemic was hitting, lots of Asian American writers were starting to put out perspective pieces, especially like Kathy Park Hoang here, talking about their experience and perspective, how this pandemic has started shifting this issue of racism to the Asian American community. She started and talked about how she's been noticing some of the slurs that she's never heard before abroad and then starting to occur in our country. Seeing derogatory words such as chink that she thought has been really outdated. And what it was highlighting was that the pandemic was bringing back these really old stereotypes of the Chinese culture. Next slide. And so then the question that our country was facing, is there really a rise in anti-Asian racism during this pandemic? If you sort of happen to look on the news during this time, there were so many stories that were being put out of many Asian Americans getting physically abused. There was a story about a man stabbing 2 Asian American kids and their father at a grocery store in New York City, or a woman getting her acid thrown at her face while she was taking out the trash. So there were multiple of these news of people getting spat on, getting refused services, and getting called racial slurs, that the FBI started wondering, is there an increase in these types of hate crimes across the country? Next slide. And then we started hearing the rhetorics that our government officials in the media was using, like Chinese virus or the Kung flu, that was linking race into disease. And the Asian Pacific Policy and Planning Council organization actually received over 2,500 incidents report of these types of verbal harassment, shunning, and physical assault since March. And if you really looked at that time, there has been no concerted efforts from our federal agency to prevent or even address these anti-Asian sentiments during the pandemic. And something very similar happened when you look back in our history at 9/11 or SARS, for example. And if you look at the chart on the right, it's actually very different than what the past has been showing, where here the FBI's report has been showing this 15-year decline in anti-Asian hate crimes. And so there's this underlying pinning of sentiment that there's this known habit that there's anti-Asian racism doesn't really exist, or it's been really drilled early on that it's minimized. Next slide. And I think to really understand this current xenophobia, I think it's important for us to understand the long-standing biases that the country or the world has against Asian Americans. It's actually deeply rooted. So it's not really this pandemic or the media that has caused anti-Asian racism. In fact, I think what's really important to understand that racism truly never disappears, but it adapts to new circumstances. So if you look back in history, in 1882, there was the Chinese Exclusion Act, where they barred Chinese laborers from entering to the country because there was concern for workplace competition, or where they were portrayed as a degraded race and that they didn't want to come to this country to be assimilated. And then in World War II, there was this huge fear against Japanese people. And in fact, that caused over 120,000 of Japanese, mostly American citizens, that were relocated to concentration camps for several years. So there's this foreign stereotype that keeps getting pushed and putting the onus on Asian Americans to really demonstrate how Americans they are and really to compensate for looking different from the country. Next slide. And so then as time went on, there's this shift to this model minority myth. And so this stereotype characterized a group of Asian Americans as this homogenous group, that we are a hardworking, polite, law-abiding group, that we achieve higher success because we are quiet and we listen. And that unfortunately actually feels, people argue that Asian Americans don't face barriers or they are protected from racism. And unfortunately, what this myth does is that it ignores the diversity and difference among different individuals and cultures within the Asian American community, like the Chinese, or like my parents who came here from Vietnam as a refugees escaping. And so it allows for a less focused approach on these marginalized groups within the community. And the myth is also used as a harmful tool to against the struggle for racial justice. So a lot of times it's brought up as evidence to downplay or deny the impact of racism and discrimination of other people of color in the US. Next slide. And so then COVID occurred, and then I think what happens is that history is appearing again. So in this figure that was put out in the San Francisco Public Health this past month in October, it showed that the Asian Americans were actually having a high rate of COVID death. In fact, in the county of San Francisco, a rate of 3 deaths for every 100 cases. And the reason sort of underlining this issue is that minority myth belief, where Asian Americans are seen as this great doing well group who has the resources, who are well off. And unfortunately, that myth has caused segments in the Asian American community to be overlooked, because there's a huge group of them who actually lack services to housing, employment. Some of the health information in COVID are not in the language that they are able to understand. A lot of them don't have access to care, either because of fear of Western medicine or fear of doctors, or just cost. And so these are not getting addressed and not getting the funded that they need. So part of it is that we can't look at Asian American as a monolithic group, because I think what happens is that there's different communities that experience the pandemic in very different ways, and they have their own distinct challenges and needs. Next slide. And what we wanted to focus on, because we all are pediatric health professionals, that how is it affecting our kids? And so there was a recent article in this past November in Pediatrics looking at the COVID racism in Chinese American families. They surveyed both over 500 parents and children. And if you look at the slide, children and parents reported a very high rate of racial discrimination, both online and in person. And if you look, children over 50% have either experienced it or witnessed it somehow. And majority of them feel that it's related to health-related xenophobia, which means this fear against Chinese people and culture, and that they are a threat to the public health and country. And now about 50% of both parents and children actually perceive that it's perpetrated by the media. Next slide. And what happens is that that racism and that discrimination really impacts the mental health in both the parents and especially the kids. And what this study also found was that the well-being was negatively impacted. The children had more generalized anxiety and depressive symptoms, and they were having issues with hyperactivity or conduct disorder. And this is actually very consistent with previous studies of other people of color who experienced daily discrimination. And I think it's really important for us as providers to understand how racial discrimination actually threatens a child's identity and sense of control, and they internalize these negative attitudes. And the other thing to think about also is that when parents experience these racial discrimination, their experience impacts their child's health, either indirectly or directly, but there's increased stress at home. Perhaps there's a hostile family environment, or they could actually have negative parenting. And the other thing to highlight in the Asian American community that they typically have a very little access to mental resources. So many of these families are not getting the appropriate service that they need to address these issues. Next slide. And this graph here, I just wanted to show it's a national study that is consistent of what we found in that past study. About 4 in 10 Americans are still saying the same thing, that people are expressing more racist view against Asians than what was happening before the pandemic. And so just to keep in mind that this xenophobia is worldwide, it's not just in this country, and it just sort of has us to reflect with danger. A lot of time it comes with this idea of searching for blame in other things. Next slide. And so COVID-19 has really revealed this disproportionate impact of national crisis on the poor and marginalized communities. And as Carmen was mentioning, that it really is deep entwined between race, social, economic, and health disparities that's occurring in our society. And it's sort of no accident that the Black Lives Matter movement sort of rose at this moment and is finally getting the attention that it deserves. Next slide. So Carmen and I wanted to take a pause here to poll the audience really quickly, just have a moment of reflection. And so on Zoom, you're going to see a poll that pops up with a question. If Ingrid, we can pop up the poll. So the first question is, have you seen an increase in racism since the pandemic? Number 2 is, have you experienced racism? And number 3 is, have you witnessed racism? So it looks like about 50% of people are starting to vote. Please continue to answer question, but it really is, for the first question, about 90% of everyone on this talk has actually seen excessive racism, and not surprising of what we have been seeing in the news. And about 50-50 have said that they've experienced racism, and 75% has witnessed racism. And again, just sort of highlights in our community here in California that we're seeing this. And the one last question we wanted to pose to everyone is, what strategies have been implemented at your institution to combat racism? We're going to talk about them in the next couple of slides, but we'd love to hear from you and the audience what you guys have been doing. And please feel free to put it in the chat as we go forward. And so I think, I think with this pandemic and the crisis, I think there are ways to look at it and see crisis as a way, as an opportunity. And part of this is like, as pediatric healthcare providers, how do we seize the moment and make the change? Because we have this great opportunity and privilege to shape the child's health and well-being, but it is also our responsibility to understand and address the needs of our patients and be able to advocate for policy and initiatives that address and these biases and these inequities that we're seeing. Next slide. So the first step is really just learning about the history of racism and how it impacts our patients and families. I think it's so important for us to learn about our own biases and how it impacts patient care in the work environment that Carmin was mentioning earlier, and then taking steps to address this and becoming an ally. We give this here, the bystander intervention, as a framework for people to see, like, these are things out there that you can do to help people who you have witnessed or experienced racism in your community. Next slide. And the second thing is to recognize that race is a core social determinant of child health that is a driver for health equities. I think race, it impacts so many different things, from birth disparities, mental health, the way our kids are put into the juvenile justice system, our education system, not having equity in terms of how our children have access to good education, public education. So there's so many downstream effects that is caused through racism. So the AAP put out a statement in 2019 to talk about the impact of racism, and then also to ask pediatricians to reflect on their own bias and how we can implement structural and individual strategies to optimize the practice and ameliorate the effects of racism on our kids. And they go into 4 different categories. And I'm just going to take a next couple of minutes to talk about the specific recommendation that you guys can take away in your clinical practice. Next slide. So in clinical practice, I think thinking of ways of integrating communication strategies or evidence-based screening tools that measure, that incorporate measures of racism into clinical practice and how it's impacting your patient, providing anticipatory guidance and to be able to allow families and patients to recognize racism, how it's different from some of the other threats, and how to safely oppose these negative behaviors and replace them with experiences that are positive. Of course, training your clinical and office staff to be culturally competent in their care, and assessing social determinant health associated with racism. And what that means is racism that's associated with neighborhood safety, poverty, health inequity, and academic access. And then, as we had mentioned, how mental health is affected by racism, making sure you address those with the patients that you see in your clinic or practice. And then integrating positive youth development approaches, such as identifying strengths and support networks for these kids, and then infusing culturally diversity into early literacy promotion programs. And part of it is to ensure that you reflect the diversity of the pediatric population. Next slide. And then the second category is the workforce-place development and education. So I think number one is training our learners on how to effectively communicate with patients and families across different populations, providing active learning communities that promote cultural humility and opportunities for us as healthcare providers to actively prepare to serve the diverse population, whether it's through a simulation or language immersion programs. And then it's also very important to diversify the pediatric workforce. We take care of a huge diverse population of pediatric kids, and it's so important that our workforce looks like that. And then provide ongoing professional education to reduce implicit bias. And third is system engagement. And what we mean by system engagement is through community engagement, advocacy, and public policy. So having interdisciplinary partnerships with other organizations that can campaign against racism, creating safe playgrounds and healthy food markets for children who are impacted by poverty, and then really improving the quality of education to allow every student to have the best educational milestone that they can, and supporting implicit bias training in schools and for educators, because there is a huge disparity when it comes to who gets suspended and who gets into the juvenile system. And then increasing access to mental health services in school, providing multicultural and multilingual curriculum, and then having policy and programs that diversify teacher workforces, because it's been shown that students of color does better when they have a teacher that looks like them. And then provide fair housing practices. And the last category is research, which is so important to have funding and rigorous research that actually studies the impact of all these implementations that we look at and look at the impact of discrimination on child and health outcome, how these policy changes and interventions work, and how these workforce development activity improve patient care. And the other important thing is to really try to incorporate human genome to improve human health instead of classifying things based on that minor genetic differences. Next slide. And then what we wanted to share things that our department is doing to combat this racism. Our Department of Pediatrics developed the Stanford Pediatric Advancing Anti-Racism Coalition, which is a group of several committees working together of how to promote equity and inclusion in their department and really focusing on policy and systemic changes. And the last other example that we're doing is through our lead program that Carmin is created, is this longitudinal program that is training residents and fellows to be future leaders in academic medicine so that they can promote issues on equity, diversity, and inclusion. And lastly, we just wanted to leave everyone with a quote before we open up for a discussion, is by Dr. Yancey at Northwestern. COVID has basically taken off the Band-Aid that was covering the wound, pointed out how deep it is, and left us with no other choice but to finally say, we get it, we see it. Thank you.
Thank you, guys. That was a terrific presentation. And there's some stuff coming in through the various channels here, Q&A, and then some on chat, and some just, I guess, the panelists. But let me just very quickly, there were a couple questions that brought us back to the Pfizer vaccine presentation at the very beginning. And I think we can just say that, unfortunately, because the data in the press release were so limited, we're unable to know much about the demographics for the cases and whether or not the vaccine prevented severe cases. Really important questions. And of course, we're all looking forward to seeing the peer-reviewed publications on that. But back to this session, let me start by asking a question about there was a question that came in, I guess, first on the panels, but now I see it here. How would you screen for and address racism-associated mental health effects? And I'm assuming this is referring to patients, but maybe you could also touch on the impact of racism on healthcare providers too.
I can answer it. So there's probably a couple of approaches. One that first comes to mind is looking at the ACEs study. So I know that a lot of the work that's been done by Nadine Burke-Harris has looked at ACEs as a screening tool, and particularly it melds in social determinants of health, but also looking at racism as well. But I think doing some training within your own staff to understand, what does structural racism look like in healthcare helps to first kind of bring that awareness. And then, there are different strategies. I think the SPARK group is really great example of looking at anti-racism as an approach to really mitigate this on many different levels and fronts within the healthcare workforce, with patient and provider, looking at, how we interact with our own teams and really kind of mitigate that. But I think the first part is understanding where racism lies and really kind of being able to call it out when it happens. Also knowing how it may differ from discrimination and harassment, because a lot of times it's kind of put all into one umbrella, but just knowing that racism is a structural component that really it's part of our country's founding to separate people and prioritize one group over another based on certain traits of ethnicity or color. So I think once you start there, you can develop more tools to address those.
And of course, so many mental health issues to be worried about in providers. And I know, at least on social media, for whatever that's worth, there's a lot of stories about people experiencing racial slurs, particularly with the Chinese virus allegations and sort of hate that's being spread. Are you guys aware of any data, or at least are you hearing about increasing concerns by providers?
Oh, I think definitely. And there were some articles by Asian American doctors and physicians sort of dealing with this mental health, because they were also getting attacked with these racial slurs. And I think this is sort of highlights the importance of allyship, right? I think a lot of times we experience this whether microaggression or overt racism. I think this is where we need to work as a community and as a country to help each other, using each other's privilege and power to help support it, because I do think it does get exhausting for the people of color experiencing this, and it just weighs on you and it takes a toll.
Thank you, Carmen and Kim. That was an excellent presentation. There's a question about diversifying the workforce, and can you speak about the importance of diversifying leadership to have more people of color in positions of power?
Well, part of your question also answers it. So I think there's a piece where we have to look at representation. So one piece, if we look at our healthcare workforce, in terms of diversity, we're still working there. We still have a lot of things that we have to do to remove barriers from people progressing through the pipeline from medical school training to residency training into faculty, and then continuing into leadership roles. But also the piece is that, you are actually seeing a difference of ideas and perspectives at the top levels of leadership. And I think that has been a big struggle because, you can only get so many amazing, innovative ideas if everyone looks the same or thinks the same. So I think a lot of times we think of diversity of thought, but also diversity of experiences and cultures is really going to kind of help propel our healthcare to another level. And I think we have to do what we can in terms of how do we recruit for faculty roles? How do we look at how we're retaining trainees onto going on into their career into faculty? How do we look at mentorship? And also that's a key part of really kind of advancing people into leadership roles. I think it's critical that we have not only that awareness, but that it's a conversation that's constantly had from bottom up and also top down.
Jessica Gold asks the million-dollar question that I suspect we could probably have an hour discussing, but she does a nice job in the question of tying together the first presentation on the vaccine with the rest of the hour. And she asks, in rolling out the vaccine, how can we prioritize groups who are especially vulnerable to COVID-19, i.e. the Black and Latinx populations, while balancing potential for stigma, because of course that's a really interesting tension there. And then B, address mistrust of the medical establishment by these groups that might in turn discourage vaccine uptake. So lots there. Who wants to start?
I can start. That's a big question, Jessica. I love it. But I think the first piece is one, knowing that, for often marginalized groups and also communities of color, there is a distrust in the healthcare system, particularly when it comes to experimentation. So I think of the Tuskegee experiment and things like that, that actually still really carries, it happened during the lifetime of my grandparents. So I know, very anecdotally, my grandmother, she hasn't had a vaccine. She doesn't believe in vaccines. And I think it has to start with, the understanding of, what are the risks that you're putting yourself at by having a vaccine, and knowing that this is, new and novel. I think a lot of education has to go into whatever vaccine is available. Like, how do we educate our communities? How do we provide resources that are at a literacy level that our patients will understand? Because I do worry that that distrust actually has been heightened during this time of the pandemic, particularly since some of our leaders have, not believed in certain parts of science and actually have eroded some of that for our patients of like, who do you believe? Do you really trust your doctors? Do you really believe that they have your best interest at heart? But also not making sure people don't feel like they are experiments in this process. I think also, as data comes out in terms of like efficacy and safety, that's going to be really important for our pediatric population. I think of just, our routine vaccines that we give for children and the families that refuse, it's going to take a couple and multiple probably conversations to try to find some, level of understanding or middle ground of why is there vaccine hesitancy, and maybe, trying to work through that. Because I think, we're being very optimistic that once it comes out, everyone's just going to sign up to take this vaccine. But we know very well that there's going to be some just hesitancy and distrust that this vaccine will work. So just working with that in our communities as well. And this is across the board beyond just marginalized groups. But I really think for pediatrics, it's really important that we have a really thoughtful approach.
And I was just going to add, I think this also highlights how important it is to include marginalized groups in rigorous research and understanding, especially as we're looking at this vaccine, how it addresses them, and not only like if it's effective, but like the aftermath of the trust and how it affects people with their healthcare system.
It's an important point, and one that I wanted to ask you guys more about, which is, how are we ensuring inclusion of a representative population in our clinical research studies? And I think so far the data suggests we really haven't done that. And it wasn't totally clear from this Pfizer vaccine study how that will fall out. But any more thoughts on how we can better do that? Of course, as pediatricians, we have really no clinical trials involving kids at all. So we're feeling a little bit powerless, but any additional thoughts on how best to represent our vulnerable populations in these trials?
I think once again, in that article that you provided, definitely if you share it with the group, it was a great discussion of one, once again, the fear of being enrolled in trials and still it being experimental. But I think there is something to be said about looking at the healthcare and also the research workforce of having, prominent African-American, Latinx, Native American health leaders really kind of talking about this. I know for the Morehouse School of Medicine, the president, he actually spoke at what's the National Medical Association, which is a African-American medical group nationally, and really just said that I'm going to go be a part of this trial because I want to prove to my community that it is safe. And so that takes a very big leap, but I think that's what's going to be needed. So, of the few leaders of color that are in those roles and positions, really kind of being engaged, being a part of these trials, I think will help to re-engage communities to participate. So that's just one example.
So Kim, you had asked the question about the strategies that you have implemented at your institution to combat racism, and we got a few answers, and I didn't know if you wanted to use that as we get to the last few minutes of our discussion and maybe wrap it up with that.
Yeah. So yeah, I think some people wrote in the chat box of, a lot of people are including more diversity and inclusion training for their faculty and bringing discussion to patient care. I think some staff at UCSF has developed healthcare advocates for social justice in these monthly series. And I think it sort of just highlights that these conversation needs to happen, these conversations needs to start, especially in our healthcare community, and having some sort of policies or systemic changes, I think is going to move us forward. I think here at Stanford, we're doing a lot in terms of our Department of Peds to help move that conversation. In our Pediatric Hospital Medicine Division, we are now incorporating things into our talking about health inequities in our journal club, in our case conference, and how we can improve the care we give to especially our marginalized patient population. And so I think it's, I hope that everyone took away from this talk of that steps to do in terms of your own clinical individual practice, because I do think it takes an individual practice for you to practice, because this is not an easy topic. But also, how can we work as a community back at your institution, back at your vision to move things forward? Carmen, I don't know if you had anything else to add.
Yes, I was just going to add, I think back so when we had our Diversity and Inclusion Forum, Steve Lee, who is an Associate Dean in Diversity here on the School of Humanities, he just talked about a lot of this, unfortunately, is very unpracticed in terms of talking about racism, talking about social determinants of health and its impacts, talking about, these inequities. So I think as we continue to have these conversations, I really, appreciate Alan and Roshini for inviting us to have this talk, but continuing this, afterwards and just talking about it, we become more skilled, we become more comfortable, and then we can really kind of interrogate, how are we practicing? Are we practicing in a just and equitable way? That's really the question at the end of the day. Is the care that you receive the same as your peer, as someone else? And really kind of, if it's not, then how do we mitigate that barrier? Is there a structure that needs to be removed or replaced and revised? And, I'm thinking of it, I almost, dare I say, from a quality improvement lens. One of my good friends has just said, like, that's how we have to look at this work, that we're constantly trying to grow and learn and do better. But I think we have to, that's our call as physicians, as pediatricians. So Thank you so much for having this conversation today. That just gets it started.
Thank you guys for joining us, and thank you to the audience for joining us as well, and for your questions and comments, and let's keep these conversations going.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.